I would like to introduce next presenter. She's presenting on Oldies, so I think we have an oldie song to welcome her to the podium. Dr. Megan Erlmeyer is my daughter. I'm very proud to introduce her. She's my oldest daughter, and more about Megan. She has 3 kids, and she's been working in pharmacy. She started as a technician when she was a sophomore in high school, and it's just something that she's been passionate about. I remember when she applied for pharmacy school, she says, "Mom, what do I do if I don't get in?" You know, and she just didn't. She had to think about what would she do. And do you remember we came up with you would be a weather girl? Because of her science background, but thankfully she got in, and she's a great pharmacist. And so please help me in welcoming Dr. Erlmeyer.
Good morning. As Judy said, my name's Megan, and I am a long-term care pharmacist. So I'm going to talk to you about that for the next hour, but before we get started, I want everyone to think about why you chose pharmacy as your career. And I'll tell you that this picture is a good example of why I do my job as a pharmacist right now. This reminds me of a gentleman so my pharmacy is located inside of the nursing home, one of the nursing homes we service. So I go up to the floors often, and there's a gentleman one time that had a suitcase packed. He was a resident, and he came up to me and asked me to call his wife because they're supposed to go to the beach tomorrow. I also have a resident that I see often that used to be a school teacher. She wheels around the nursing home with her little baby doll. And then my favorite resident is my favorite because she reminds me of my grandma. Every time I get off the elevator, she's always in the commons area, and she shouts my name. I think everyone can hear, and she always asks how my boys are doing. So those are just a few residents that make me feel special, and they are why I do my job and do it to my fullest potential. So our objectives today are to discuss the differences between cycle fill and daily fill in long-term care, discuss the importance of advocating for long-term care patients, and discuss the unique long-term care pharmacy laws. So no matter the pharmacy setting, they're all very similar when it comes to workflow. There just might be little differences like how medications are packed, different laws, or different protocols. And these differences are put in place to protect and serve our patients. So in long-term care, orders originate from pharmacists, providers, and nursing staff. There might be a nurse that's caring for a patient and sees a need for medication, so they contact the prescriber, and then the prescriber gets back to the nursing staff. Same way with pharmacists, we might come across a drug interaction or a medication that a patient's not taking. We think it needs to be discontinued. So we contact the prescriber and they get back with us. When the orders are received by the pharmacy, they start at order entry. So the medication is entered into the computer system. And then some pharmacies, it goes to verification for the pharmacist. At our pharmacy, we save that step till the end. So we go from order entry, a label's printed, and then the filling pharmacy staff fill the medication, and then we have the pharmacist's final check, and then the medication is delivered. So as you can see, our workflow is very similar to other settings, whether it be retail or hospital. In long-term care, we do group our orders into a few different categories. So we have our stat orders, which there again is very similar to hospital. Say we have a patient that's having a behavior, the nurse gets an order from a provider to start a psych med for relief to help the combative patient. We also have cycle fill and daily fill, which we'll talk about in a little bit. And then we have our controlled substances. In some long-term care settings, and I believe I've seen it also in other settings, there might be rooms where the controlled substances or areas where they're kept separately, and then 1 or 2 technicians are trained to fill those substances. So like I said, pharmacy settings are similar, and a small difference in long-term care pharmacy is how the medications are packaged. So here I have right in the middle a picture of a blister pack or a bubble card. This card is what's considered a number card because you have the numbers 1 through 31 there. We also have PRN cards, and our PRN cards look exactly like this. They're just red. And then you can have day of the week cards or NARC cards. So the bulk of long-term care filling is in bubble packs. Some facilities request for their medications to be filled in cassettes or pill organizers, and that is generally done to give their patients more independence. So going into daily fill and cycle fill, assisted living facilities and some nursing homes receive their medications on either a monthly or every 4-week basis. The medications that are in cycle fill are your maintenance meds, such as your blood pressure meds, pain, psych, cholesterol, heart failure meds. And the facility decides whether they want their medications received every 4 weeks or if they want them received on a monthly basis. And this is good in a few ways. Their nursing staff know that they don't need to request the refills for their maintenance meds. We're able to bill and start filling those medications 2 weeks in advance, and so we can make sure that we have a script for the patients so they don't go without their medication. It also helps with time management in the pharmacy. And then on the other end, we have our daily fill medications, and these are our short duration orders such as antibiotics, orders that change often like Coumadin or some pain meds, all of your PRN orders, whether it be Tylenol or Haldol, and then our bulk medications such as insulin, inhalers, eye drops, and whatnot. So here is a picture of the day of the week cards because you can see they list the days of the week. This is an order for cephalexin 500 milligrams 4 times a day for 5 days. So it's a daily medication because it's a short duration. This medication is ordered to be given 4 times a day, so we have 4 cards. There are times when we pack multiple pills in the bubble. So say we have a medication that's take 2 tablets by mouth in the morning, we can put those 2 tablets in 1 bubble. If we were to take this order and put all 4 capsules into 1 bubble, there's 1 of 2 things that would happen. The nursing staff would notice the directions and see it's packed wrong, and they'd have to destroy 3 of the capsules and give 1. Or there's a possibility the nursing staff would not read the directions and they'd give all 4 capsules in the morning. So we want to make sure that we have the number of cards for how often the medication is given. And we only pack 1 medication per bubble. So if we take, say, lisinopril in the morning and an aspirin in the morning, we would have a lisinopril card and an aspirin card. We would not put both pills in the package, and we do that for a number of reasons. We need to be able to identify the medication as well as the nursing staff needs to, and then obviously if the order was to be changed. Some other things to note here is that it's important that you put the correct time sticker on the card. There's been instances where an order was to be given in the evening and it had a bedtime sticker, and so you'll see later in a video the bedtime medication was at the back of the cart, and it was evening time. They administered the med. They didn't have that med because it was stickered incorrectly, and so they marked it as not given for a week, and they were requesting a refill, and then we caught that it had been stickered wrong. With this order, it came in on a Monday morning, and we knew that the facility was not going to be receiving the medication until afternoon, so our order entry technician made sure that she started the dosing package on Monday midday, and then also relayed the information on to the filling technician to make sure she started the antibiotic on Monday midday. Had the filling technician started the order on Monday morning, What would have happened is the cards would have been delivered and the first dose would have been given on Monday at 5 p.m. and the patient would have missed 2 doses. They would have missed the morning and the noon dose because the nursing staff are trained to follow the cards and follow what's on their MAR, and so those 2 doses would have been missed. This medication, methotrexate 2.5 milligrams, take 3 capsules by mouth in the morning on Wednesday and 2 capsules by mouth in the evening on Wednesday. So once again, we have a medication that's taken 2 times a day, so we have 2 cards. The important things here, well, this is a cycle medication, so it would be in cycle fill. And we wanted to make sure that we packed 3 tablets in the morning and 2 in the evening, and that we also put it on the correct day of the week. If it would have been in the Tuesday slot, there's a chance that the patient would have missed their medication for that monthly cycle fill because it doesn't populate on their Tuesday MAR, and when it comes up on their Wednesday MAR, they might not connect the dots that it was in the incorrect day of the week slot. On the top left, I have a picture of what the inside of the drawer of a med cart looks like. So you can see all your bubble pack cards, and then there's what's called a lock box. So the nursing cards are locked, and then within the cart, there's what's called a narc box or a lock box. The facilities decide what they want in the lock box. Our nursing staff keep the C2s in that lock box. We used to keep lorazepam and tramadol in there. We don't anymore. So again, it's not a law what's kept in there. It's up to the nursing facility as to what they want to keep in there. And then I also have a picture of our controlled substance, our NARC cards that go in those boxes. They're about half the size of our normal cards. As you can see, that box is pretty small, so we use those smaller cards to help make more rooms for other medications. And then I also included a sample of a count sheet. So generally at the top there you put a label that has the patient's name, medication, and then when the medication is received by the nursing staff, they write down how many tablets they receive. And then every time the controlled substance is administered, they mark that down. When the nursing staff is done with the shift, they count their cart and make sure that all the numbers match, and then the oncoming nursing staff counts the cart and verifies that the previous count was correct. So I'm going to play a little video for you that shows an example of a med pass to kind of help you understand why we package medications the way that we do.
Hi, my name is Shawan Brooks. I'm a pharmacy tech and also a med aide. And today I'm going to teach you about the med card.
Can you guys hear this? Okay.
So this is the med card. It has several drawers. It has a sharps container on this side. It has a trash on this side. It has a computer right here and a scanner that we use to scan medicine. And so it will be locked. You have to have a key to lock and unlock it. You never leave this unlocked and walk away. It has a stopper, so if you roll into a room and you need to stop, you can stop it. It has several drawers, and this is where your patient's medicine is going to be. You're gonna have, this top drawer is gonna be for your inhalers, eye drops, and then the bottom drawer is going to be where you keep your meds at. And as you can see, we have them organized for morning, noon, midday, evening, and bedtime. And the PRNs are always in the back. So when you start your first med pass, you're going to get your morning meds out. Make sure that the resident's name is on it. And make sure that you got the right time. And then you want to start scanning, and when you scan, it'll let you know if you don't have the right med, if this is not the resident's med, it'll alert you. So that way, you can know what you're doing. Now, you want to get your medicine out, and you want to pop each one into the container after you scan them and make sure that they belong to them. So you scan, pop, scan, pop, scan, pop, scan, and pop. So this would be where your resident's medication is. So then you would get your water or whatever and give your resident the meds, but make sure that you know that's the resident, that's their name. Ask them. If they can't remember, go ask somebody. Don't just give them this medicine if you're not for sure who it is. So then you want to take your meds, put it back in the cart, and you want to rotate them because some meds are given more than once a day. So if they take that med in the morning, noon, and bedtime, you want to make sure you got your noon meds up next because that's going to be your next med pass. And then sometimes if they are big pills, you have to your card will say 1 of 2 or 2 of 2, so make sure that you give those. And then once you're done, you want to push this back in, lock your cart, sanitize, and then go back to the next patient.
So I took a couple pictures of what Shawan was demonstrating. So as you can see with the bubble packs in the med cart, each patient is separated by a divider, and then each patient's meds are organized by time of day given. And that's just so the staff they do one patient at a time. They can pull out their morning meds, administer them, and they put them at the back of that patient's spot. And then the next time Shawan needs to go administer her medications, her noon ones will be ready to go. And then I also showed the picture of what normally your top couple of drawers are reserved for your smaller bulk meds like your inhalers and your eye drops, and those are also divided out by patient with organizers. And then your very bottom drawer is where you have your bigger bulk meds like your Milk of Meg or your big bottle of liquid Tylenol. So some long-term care pharmacies make their IVs in-house. Others outsource them. We don't have much of a need for IVs at our facility, so we outsource ours. The pharmacies that have them in-house, it's a lot like controlled substances where they have 1 or 2 technicians trained to do their IVs. Another pharmacy duty performed in many settings is medication reconciliation. MedRec is the process of comparing a patient's medications to all of the medications that the patient has been taking, so their orders to what they have been taking. The reconciliation is done to avoid medication errors such as omissions, duplications, or dosing errors. So many providers, as you can see here on this slide, perform medication reconciliation, and you as pharmacy technicians are team members that are able to perform the reconciliation or assist with the process. So I'm going to show you a video on medication reconciliation. It's kind of long, so I am going to go from this point so that I can skip ahead a little bit. This one's quiet, so we're gonna get the volume turned up too.
Hi, I'm April and I work in a long-term care facility pharmacy. And today I am going to show you how to do admission reconciliation. And we're going to start with a new admission. This is what the nursing staff would send down to the pharmacy for us to start entering. And you want to look for any allergies, and then they will send down their written orders. So then you would reconcile between the 2 lists, and you want to make sure that you go off of one list and then check the other list so that you don't miss a drug, and you want to make sure that the release forms and the milligrams are correct. So I will show you how I do this. So I would start with this Eliquis 2.5 milligram by mouth 2 times a day, and then I would find it on the admission orders and make sure that they wrote out the 2.5 correctly and 2 times a day, and then I just check it off and check it off here. And then I move down to the carvedilol, 6.25 milligram, 2 times a day with meals, and you want to make sure that they wrote up that it's with meals. And then you just check it off. And then we have ciprofloxacin, 500 milligrams, 2 times a day for 7 days. So I find it over here, and they wrote it for twice a day for 7 days. Pantoprazole 20 daily, and that's correct. Tylenol with codeine, 300 milligrams with 30 milligrams every 6 hours, as needed for pain, 2 tablets. So you want to make sure that they wrote up the 2 tablets. And it's only a 5-day duration that they wrote that up. Levothyroxine, 1 daily, 75 microgram. And that's correct. Lisinopril 10 daily. That's correct. A multivitamin with minerals daily. Allopurinol, 100 milligrams daily. Buspirone, 5 milligrams, 2 times a day. And here they wrote it up as buspirone 5 milligram, 1 tab daily. So we would call up to the nursing floor and let them know that that's written up wrong. Or if they find out if they got a new order, to change it to daily. Before, and it doesn't look like she's been on that, so I'm going to star it to know that I need to enter that as a new medication. And then we have Keppra, 500 milligram. Take 1 tablet by mouth 2 times a day for 1 dose. So I'm going to star that to dispense 1 tablet. And then we have aspirin, 81 milligrams chewable daily. And it looks like that's correct. Even though they show that it's a change, we have 81 milligrams chewable, 1 tablet every day.
So the order set that April's working on right now is a readmit, and so what we do is we print the MARS from before the patient left the facility to go to the hospital, and then she's comparing it to the hospital discharge orders to see what was changed. So what I had her do is I just pulled 3 admits for her. I pulled like a new admit, a readmit, and then a new admit with the discharge orders that we get in a different way. So generally we have anywhere from up to 6 admits a day, and we get the hospital paperwork normally at a pretty decent time. And so if it's a readmit, she's able to compare them right away. And then the other orders, we have to wait until we get the verification from the provider. Generally, she knows that it's a job that she just does to complete it to make sure that there's not any errors. And normally she just doesn't answer the phone. We take care of that for her, so she doesn't really get interrupted when she's doing the medication reconciliation. So I'm just going to fast forward just a little bit more. There's one other type of way that we get orders.
Are not supposed to be on it. And then I would start entering the differences that I marked. Next, I'm going to show you another type of new admission. This is another way that we receive orders. It's just a med list. And then we would also get e-scribes. So I would reconcile between the e-scribes and the med list to see if there's any changes. So for example, this one is acetaminophen 650 extended release to take 2 tablets every 8 hours as needed for pain. And this says acetaminophen 650 extended release, 2 tablets every 8 hours as needed for pain. So that's correct, and that's correct. And then I have amlodipine, 2.5 milligrams once a day. And then I would just double check those and keep going between the 2 med lists and making sure that you stick with one list and check off the other list.
So I went ahead and took copies of the information that April had just to go over what she did real quick. So on the right-hand side, we have the hospital discharge paperwork, and you need to keep in mind that the hospital discharge orders are not prescriptions. If you're discharged from the hospital, you can't take what's on the right-hand side into a Walgreens or CVS and fill it. So it's the same case for us in long-term care. Sometimes with hospital orders, after all the orders, it'll say electronically signed by and have the provider. So if they're legend drugs, we fill off of that. If they're controlled drugs, we still make sure we get a script. Sometimes the provider will only electronically sign the new orders, and so we will fill the new orders, but not the previous orders. So what happens is that the hospital discharge paperwork is sent to either the nursing staff, and then they send it to us, or we receive it. And then, since they're not actual prescriptions, the nursing staff contact the provider and get orders based off of the discharge paperwork. So our medical director for our nursing home and our assisted living is the provider for most of our residents, and she likes to work via text. So our nursing staff will take a picture of the hospital discharge papers, and she'll respond back by either saying follow hospital orders or make these changes. And then from there, the nursing staff have a couple options. Sometimes they'll just write on the hospital discharge paperwork the changes. Sometimes what we would really like them to do is put the orders onto their admission orders. So on the left-hand side is our facility's admission order forms, or they can enter it into the nursing system, and then it shoots over to the pharmacy as an e-scribe. So the first example April showed you was where the nursing staff sent a message to the provider, and the provider responded, and they transcribed the information onto the admission orders, and that's what we filled off of. So when April was doing this med rec, towards the end of the first video before I clipped it, you saw that the order was for buspirone 5 milligrams 2 times a day, but the nursing staff had written up buspirone 5 milligrams daily. And so that's where you'd contact the nursing staff and ask if it was an error on their end or if it was a change that the provider wanted. The second example that I showed you a little bit of was a readmit. So like I said, we print off the MARs from when the patient was at the facility before they left for the hospital, and then we get the discharge paperwork. And there again, the nursing staff send that information off to the provider and get the orders okayed. A lot of times the provider will say follow orders prior to hospital stay. Sometimes they'll say okay with hospital orders, or they'll do a mix of both. And so what we do is we do medication reconciliation with what the patient was on before their stay, during their stay, and then what the provider wants. And that's just to make sure, say the patient left our facility and the nursing staff faxed them their MARS and the hospital got 2 of the 3 pages. And then the hospital does their reconciliation, but with the 2 pages they received, and so there's medications missing. And then obviously we want to make sure that from the hospital orders and what the provider okays, that the nursing staff relayed that to us correctly. So this is an example on the left-hand side of a communication with our nursing staff to our medical director. So you can see that the nursing staff took a picture of the discharge paperwork, and the provider said to stop the statin, change Tylenol, 1,000 milligrams TID for pain, stop the Miralax, and ordered Senna Plus 2 tabs by mouth daily as needed for constipation. The nursing staff took these changes and put them into their system, which came to us as an e-scribe. And you can see there that they entered Senna Plus 1 tablet by mouth daily as needed. So when I was doing this reconciliation, I came across this error on the nursing end. So I just contacted the nursing staff, and they were able to correct it on their end. Here's another example of communication between our nursing staff and the medical director. At the very top, you could see where they took a picture of the orders and sent it to the provider, and the provider responded with, I don't see any modifications. This was between a readmit, and so the provider didn't see any differences from the hospital orders to what the patient was on. And so the nursing staff responded with, the order was changed to Tylenol 500 3 times a day instead of 1,000 milligrams, and that the resident had a new order for nitro. So the provider went ahead and said, add the nitro, otherwise resume previous orders before hospital stay. So when I was doing this medication reconciliation, I compared, like I said, the patient's previous orders to the hospital orders to this notification that we got, and from the previous MAR that we had to the hospital orders, the hospital had also ordered Protonix 20 milligrams 2 times a day. So there I contacted nursing staff and let them know that the hospital had also added Protonix to the patient's med profile, and they got an order from the doctor to continue the Protonix. So as you can see, like with the couple of errors that we caught between the buspirone, the Protonix, and the Senna, the patient's med profile wouldn't have been complete. The patient with not having the Protonix could have had some GI problems until they got that order put back onto their profile. So another unique law in long-term care is the use of the emergency box. And emergency boxes are allowed in nursing homes, but not assisted livings, and they're a privilege in nursing homes. So if they're abused or meds are being diverted, there's something that we can pull from the nursing home. They're stored in a med room or an other secured area. They're sealed by the supplying pharmacy, and they're sealed in a way where we can know if the e-box has been accessed. They're labeled as an e-box for emergency use only and have the pharmacy's information. They also contain a list of the medications that are in the e-box, the strength, the route, the quantity, and the expiration date. The emergency boxes are inspected at least on a monthly basis, and then every time it's accessed. And the medications in the e-box are limited to drugs that are required for immediate use. So examples of medications that are in our e-box would be pain meds. So say middle of the night, a resident gets up and falls and has some pain in their wrist, they can get an order from the provider to administer tramadol out of the e-box. If a patient in the evening is having some behavior problems, the nursing staff is able to contact the provider, and the provider might write for a PRN, lorazepam, or Haldol to be administered. Antibiotics are in our e-box. the glucagon pens are in our e-box. So those are just examples of some emergency meds that are in the e-box. As I said, though, if there's something that needs to be pulled from the e-box, the nursing staff needs to either make sure they have an order or call the provider to get an order. And then that order is sent to the pharmacy along with what we call an e-box usage slip, so we know what was pulled from the e-box. So when it comes to pharmacy law, it's important to remember that you have federal law and state law. You generally follow federal law unless state law is more stringent. So a federal law that's not exclusive to long-term care is the ability to do an emergency filling of a C2 from a over-the-phone order. This emergency fill order needs to be immediately put to writing. You need to, the quantity prescribed needs to be limited to the time during the emergency. The script that you write out needs to be written authorized for emergency dispensing. And the mailed script needs to be received within 7 days, or if it's e-scribed, the mailed script needs to be postmarked in 7 days, or if you receive like an e-scribe, it needs to be received within 7 days. Another law that has helped me out in the past is one that advocates for a number of our long-term care residents, and it's the ability for pharmacies to receive C2 prescriptions faxed, and this is for nursing home residents and hospice patients. The emergency fill and the faxing of C2, it'll be interesting to see where those laws go in the next few years. With the e-scribing now, I don't feel those laws being as pertinent, but I have used the emergency fill law a few times myself. Say we have a resident that we know is going to run out of their pain medications, and we fax the provider, a week ahead of time, make a phone call, and we don't receive the script, and they're going to run out of the weekend. I've called and gotten one over the phone to make sure that my patient doesn't go without their pain medication. And then if you think about it, you and I, if we fall and injure ourselves, we're able to go out and then we bring a paper script to our facility, or they e-scribe a script. Our nursing home residents, they don't have the ability as easily as we do to go out and get a script and bring it back. And so the C2 faxes that can come through for our nursing home, that's really been helpful for them. And I had one more on there. So partial filling is allowed in multiple pharmacies. And so this is when the supplying pharmacy is not able to fill the whole quantity. So they note the quantity that they did supply on the prescription, and they fill the remaining within 72 hours. For long-term care patients and terminally ill patients, the law has just a small difference, and that's to accommodate the patient. So the remaining script does not have to be filled in 72 hours, but instead we have to record on the patient that it's either a terminally ill patient or a long-term care patient. We have to, each time we deduct pills from that script, we have to record the date, the quantity dispensed, the quantity remaining, and the pharmacist's name. And then that script is valid for 60 days. And you might wonder, like, why we would do it this way, and one reason is for insurance purposes. Like hospice patients are generally a 15-day supply is what they can get. So if you have a script for 90 hydrocodone, that's 3 times a day, the insurance might not let you bill that. Or some facilities might only accept so much of the control medication at a time, and that's to help with diversion. So at our facility, at our nursing home, for scheduled C2 prescriptions, we only dispense a 7-day supply at a time, and that helps with diversion. It's a lot easier to keep track of a week's supply of one patient's C2 versus 90 pills that are given given 3 times a day. So those are kind of 2 reasons where this law helps with the diversion and protecting our patients. So throughout this presentation, I've noted some laws and some practices that are in place to advocate for our patients. The biggest way that you can advocate for your patient is by reducing medication errors. So I jotted down 10 strategies in reducing medication errors. Number 1 is to minimize clutter. Number 2 is to verify orders. 3, use barcode scanning. In our pharmacy, we do not use barcode scanning. Our technicians just check the NDC. The barcode scanning would obviously be a step to put in place if we found that some medication errors were happening. And then a lot of nursing staff or hospital staff, they use barcode scanning. Number 4 is to be aware of look-alike, sound-alike drugs. Number 5 is to have a second pair of eyes check prescriptions. 6 is design effective warning systems. 7 is involve the patient. An example there would be with your medication reconciliation. Patients are involved with that process. Number 9 is to be proactive. I think I gave you an example with cephalexin. If you're the order entry technician and you want to start it at a certain time, make sure you relay that on to your filling technician to avoid patient missing doses. Number 10 is to track medication errors, and I skipped number 8 for a reason, because I feel like that's the most important one, and that's trust your gut, which I've done throughout my practice, and it's caught a couple of errors that could have been pretty big. So number 8's my take-home one, which is to trust your gut. So when you are doing your job, just keep in mind why you do your job. Advocate for your patients and make sure that you speak up, because if you feel like something's wrong, there's probably a way to fix it. So I have just a couple questions here. What is medication reconciliation? Does anyone want to tell me what the answer is to this here? B? I heard B. Yes, that's correct. So matching prescribed medications to a diagnosis, although it's important, and especially in long-term care, when we're audited, if we don't have a diagnosis connected to a drug, the facility could get dinged for that. C, making sure medications are prescribed correctly. Again, although that's something that's important, it's not the sole purpose of medication reconciliation. So the answer is B, the process of comparing a patient's medication orders to all of the medications that the patient has been taking. Who can help with medication reconciliation? All of the above, that's correct. When is it okay for a pharmacy to accept a C2 prescription via fax? Correct. So, yep, B and D is the answer. Your hospice patients and your nursing home patients, and that's not just when you're in a long-term care setting, but if say you work at a Walgreens and you receive a fax for morphine for a hospice patient, you're able to fill it via fax. Which of the following statements is false? A, oftentimes antibiotics are included in daily fill. B, all facilities receive medications from their pharmacy the first of every month. Or C, cycle fill consists of mostly maintenance meds. That's correct. So antibiotics are often prescribed for a short duration and are therefore in the daily fill category. Some facilities opt for every 4-week basis, or even if they're on a monthly basis, they might get start their cycle fill the 15th of every month. And maintenance meds are those that are taken daily and do not change often. Which of the following is true? Emergency boxes are allowed in both nursing homes and assisted living facilities. E-boxes are to contain only meds needed for immediate therapeutic use. Nursing staff can pull meds from the e-box when deemed necessary before a provider has given an order. Or D, all nursing homes must be equipped with an e-box. Correct, true. So e-boxes are not allowed in assisted living facilities. Nurses must have an order before they pull a medication from the e-box, and e-boxes are a privilege in nursing homes. They're not a requirement. Any questions? Yes?
Was your pharmacy technician actually administering the patient's medications to them?
No.
Okay.
No, those were actually just meds that we needed to destroy, and I just kind of set them up to do a video because I think it demonstrates the need of when a medication is administered 3 times a day to have 3 cards, or why you put the time of the day stickers on them. So yeah, it's just a mock. But I mean, she is a med aid also, and so she demonstrated a med pass correctly. Yeah. Any other questions? The one that did the med rec, like 20 years. And then the gal that did the med pass, she was a med aid in our nursing home before she came down to the pharmacy. And I think she's been in the pharmacy for 6 years now, but she's been with the organization for probably 15 years also. So. We celebrate everybody's birthday, and we do a lot of pizza Fridays. Yes.
Very nice job, Megan. I think it's really, those of us who are familiar with long-term care, good review. Some of us have never filled bubble packs, so it's really neat to see what happens in long-term care, and then see, I think, what happens with the dispensing, what happens once it leaves the pharmacy. So really neat. Thank you.